Hello everyone, this is Kitty Clinical here with our next video, and today I want to talk about something very important, and that is code blues. How should you handle a code blue? We're going to talk about ACLS guidelines, and this is going to be a very high yield topic. If I were you, I would take some notes or I would follow the instructions given. So one of the things that I would recommend you do is I would go to the App Store and I would type on the go. There's also Code Scribe, which is a good one. Code Scribe is an app that, there might be various apps, not just one called Code Scribe, but it gives you the ability to document codes. It's only really good if the patient coded right in front of you and you're able to start the code right away. But more often than not, when you're handling a code and let's say you're the resident on call, or you're the attending, or what have you, you're the intern, you're going to go into it and you're going to almost be like entrenched in the middle of a code. Like, people are already doing compressions, people are already taking time, people are already giving epi, right? So when you go into a code, first of all, I would try to figure out, is there somebody already taking charge of the code, or is there not somebody? If nobody's stepping up to lead the code, to run the code, then you're the doctor. I would step in and take care of that. But go to your app store and type on the go. This is an app created by the American Heart Association. They have guidelines here. I want you to download this app, and you're going to see, when you open it up, you're going to see a lot of boxes, okay? And the box I want you to go to is the one called CPR and ECC. You're going to click on that box, and then you're going to go to the top. Okay, so as of the filming of this video, it is October 2023. So things might be a little different, but as of this month, if you open the app, make sure it's also up to date, because one of the perks of having an app on your phone is that they regularly update the app. You're going to go to CPR and ECC at the very top right. So it should say adult cardiac arrest ... You're going to hit that. And it's going to give you the algorithm. It's going to ask you blah, blah, blah. Is the rhythm shockable? You can follow with me on this. I'm going to hit PDF, and it's going to bring you to the algorithm itself. So this is the algorithm that is used for everyone, really, in the United States at least. And it's something that I definitely recommend you follow. It's very, very important that you know how to do this as a doctor. And I will say that we've gone to so many centuries and millennium of humanity, and we've gotten to the point where we are today, where medical technology is so advanced that you are seeing the adult cardiac arrest algorithm optimized for human survival right now. The screen that you're seeing right now, when you click on the adult cardiac arrest algorithm PDF, you'll see this little algorithm. That is the evidence-based, tried and true way of saving someone's life if somebody coded, or if someone's heart stopped beating. This is how to do it. And this has been scientifically proven, right? Because people have done codes and they've brought people back to life. Haven't brought everyone back to life, right? But they've brought people back to life through this algorithm. And you got to admit that this is to save someone's life like this. This is crazy, right? It's almost like magic in a way, but it's not magic. It's evidence-based, most advanced medical technology we have today. And if in 100 years from now, it's going to change, right? It is going to change. But we have epinephrine, we have all these drugs, and the tried and true chest compression. Not just give compressions, but how to give compressions, how often to give compressions. This is all really important stuff. And it's 2023, and we are at the highest, most advanced point in time of medical technology advancements that we are today, that we can give the best algorithm that we know of for saving someone's life. So with that in mind, what is your number one step? Well, before we get into start CPR, I do want to take the time to get you to realize that you should probably look at the patient's chart, because you're in the hospital setting and you want to look at the code status. What do I mean by code status? I mean, are they full code, or are they DNR DNI? If they're DNR DNI, that means do not resuscitate, do not intubate. That means they don't want chest compressions. They don't want to be intubated. They don't want to any significant life-saving measures that would save their life if their heart were to stop beating, or they would stop breathing. Now, keep in mind that code status changes all the time. One day, someone might decide to be full code, which means you do everything you can to save their life. The next day, they might decide to be DNR, DNI, and that's okay. Even if they have a living will, people's minds change all the time, right? The important thing is that you have to make sure you document everything, that you know exactly what you're doing. But if you look at the chart, if they're DNR, DNI, do not give compressions. Stop what you're doing. They decided that they wanted their life to end, and that's happened before where people did not look at the code status. They brought the person back to life, and then lo and behold, that person actually sues the hospital for saving their life. Why? And they had a good case for it, because they said they didn't want any life-saving measures, and the hospital brought back their life and probably brought in more suffering, is the reasoning here, right? So just be careful about code status. Make sure you know your code status. And let's say they're full code, so you start compressions, you start CPR, you give oxygen, you attach the monitor, attach the defibrillator, and you do CPR. You check see if the rhythm is shockable. If the rhythm is shockable, then you shock. If the rhythm is not shockable, then you're looking at either asystole or PEA. PEA stands for pulseless electrical activity. That's when you look at the monitor and there's electrical activity, but you don't feel a pulse. If you don't feel a pulse, that means they're pulseless, right? By definition. And so PEA stands for that. And asystole is also the same thing. There's no pulse, and there's no heartbeats or heart rhythm or anything like that. So in that situation, if they're in asystole or PEA, give epinephrine as soon as possible. Do CPR for 2 minutes. Try to obtain IV or IO access. IO stands for intraosseous, and that's a really great way to get access to someone's blood, by the way, through IO. And then you want to do epi every 3 to 5 minutes. And at this point, you'd want to consider an advanced airway, capnography. Realistically, you're getting someone to call anesthesia right now, because if they're in a code and you're giving compressions, listen, they're going to be intubated eventually, so you need to get a head start. You don't just wait until the algorithm says consider advanced airway, blah blah blah. No, you want to take initiative and get an anesthesia on. I mean, they should be on their way already, because the hospital would have called for a code blue, right? And then you try to assess if the rhythm is shockable. So we go back to when we first started the CPR. We're always checking to see if the rhythm is shockable, right? So if the rhythm is shockable, how do we know it's shockable? We know it's shockable if they're in VFib or if they're in pulseless VTAC. So those are the two situations at which you would shock. I would take the time to look at an EKG and appreciate the morphology of VFib or VTAC. Because if you see that on the monitor at a pulse check, you shock them. Where are we? Let's go to the asystole route. So let's say you started CPR, you attach the monitor, you check the rhythm is shockable. No, they're in asystole or they're in PA, so you give epi as soon as possible. You do 2 minutes of CPR, you get IVIO access, you do epi every 3 to 5 minutes. Then you assess to see if their rhythm is shockable while you're doing the airway stuff, right? If the rhythm is shockable, then you want to go to the point at which you shock them. And that would be step 5 of the algorithm. This is where you do CPR for 2 minutes, epi every 3 to 5 minutes, and then the advanced airway. You shock. You see if the rhythm is shockable. After a pulse check, you do shock, CPR, and then I'd probably want to consider amiodarone or lidocaine at this point, and look for treating the reversible causes. So then you keep going through the cycle of checking to see if the rhythm is shockable. Every 2 minutes you do CPR, and between that you do pulse check. You do epinephrine every 3 to 5 minutes. So realistically, you can do like epi every two rounds of CPR, right? If you can think of it like that, because epi every 3 to 5 minutes is like every 4 minutes, right? So if you're doing CPR for 2 minutes, get a pulse check, continue CPR, give epi, CPR, pulse check, CPR, epi, at the next pulse check, CPR, pulse check, CPR, pulse check, give epi. So you see where I'm getting at, right? You can do it every 2 rounds of CPR to make it simple for yourself. But going back to asystole, epi, ASAP, CPR 2 minutes, rhythm shockable. If the rhythm is not shockable, you give CPR, you treat the reversible causes, and then you check to see if the rhythm is shockable once more. Now let's go to VFib or VTAC. So the patient codes, give CPR, give oxygen, attach monitor, attach defibrillator, check to see if the rhythm is shockable. If the rhythm is shockable, such as in the case of VFib or pulseless VTAC, you give a shock, CPR for 2 minutes, get IV IO access. Realistically, you should have already had IV access by this point. And then you check to see if the rhythm is shockable. If no, then you go to the step 12. But if yes, then you go through that whole process that we talked about before of shocking, CPR 2 minutes, epi every 3 to 5 minutes, consider advanced airway, capnography, rhythm shockable, yes, give a shock, CPR, and then you can consider amio or lidocaine. What are the dosages for drug therapy? For epi, very simply put, it's 1 milligram every 3 to 5 minutes. Amio, IV or IO dose, the first dose is always 300 milligrams bolus. The second dose is going to be 150 milligrams. So I would remember that. Those are some numbers I would definitely remember if you're going to run a code. Remember, amio 300, second dose 150. Lidocaine, IV or IO is going to be first dose 1 to 1.5 milligrams per kilogram. So if they weigh 70 kilograms, you can just make it simple for yourself and say 70 milligrams of Lido. Second dose is going to be 0.5 to 0.75. So if you want to make it easy for yourself, just take the weight in kilograms. The weight should be in kilograms at the patient's chart. I would just half it and then just say that's how much Lido you would give. But that would be, you would give that after, actually you'd give that after at least 3 shocks, right? Because you would have shocked them for the pulses. You would have given them, I guess you could do, I guess it could be 2 shocks actually. So you would shock them for the first VFib VTAC. You do CPR for 2 minutes. See if you do a pulse check. You shock them, CPR. Then you do epi every 3 to 5 minutes. Then you shock them again, and that's when you would do the amio or lidocaine. So that's 3 shocks. But if the first time you do the check, they go into asystole or PEA, then you don't shock them. Obviously, you give epi instead. You do a round of CPR, see if the rhythm's shockable. If yes, then you shock. Then you do the epi every 3 to 5 minutes for CPR, and then you shock them again if the rhythm is shockable, and then you do amio lido. So if it's VFib or VTAC, it's 3 shocks. If it's asystole or PEA, it could potentially be 2 shocks, right? Just looking at the adult cardiac arrest algorithm that I am looking at right now. What are the reversible causes? So this is going to be very important. A lot of people forget about the reversible causes. And those are your H's and T's. Remember your H's and T's, okay? So that's going to be, H's are going to be hypovolemia, hypoxia, hydrogen ion, hypo or hyperkalemia, hypothermia. And your T's are going to be tension pneumothorax, tamponade cardiac, toxins, thrombosis pulmonary, thrombosis coronary. Why is this important? Well, folks, it's because you could easily bring someone back to life through understanding that some of the causes of death are reversible. So what do I mean by that? Well, hypovolemia is one. If they have low volume, they have low perfusion, and they're not getting enough oxygen to the rest of the organs, right? So if you give them some volume, you might actually save their life. They should already have, ideally, they should already have like some IV fluids running. I mean, most of the time they do, right? More often than not. But if they have hypoxia, you can give them oxygen, and that actually might save their life too. But I mean, most of the time they've already had nasal cannula, or they already have a non-rebreather. Maybe they're on BiPAP. You definitely want to intubate them at the point where they're not breathing, and you're trying to really obtain ROSC. Hydrogen ion just means acidosis. Lactic acidosis is the most common one. You'll see this often in sepsis. And this is why you want to make sure you see if the patient, if they came in with pneumonia, are they septic? Hypothermia, cold sepsis, right? So give them a heating pad if they're cold. Treat the acidosis. You can give them bicarb. Bicarb is always something you can give if you don't know what you're doing. Because the thing is, Folks, if you don't know what you're doing and you want to try what you can to save this person's life, try. You have nothing to lose. The patient's already dead. You can't kill them even more if you're doing life-saving measures, right? If you're taking life-saving measures and it don't work, then you can't blame yourself. You did everything you could. That's a very important thing. Hypo or hyperkalemia. This is why you check a basic panel. I would probably do a CMP, but you could also just do a BMP, basic metabolic panel. See what the potassium is, but also I would see what the magnesium is, right? Now, if you see torsades on the monitor, you can probably just give the magnesium. Just give the magnesium. But it's never a bad idea to check magnesium. You maybe even check a FOS if you would like. It's never a bad idea to do those things. Tension pneumothorax. You can consider getting a chest X-ray. Usually this would be a stat order. Ideally, this would have been before you had already coded the patient, because if the patient had a tension pneumothorax and then all of a sudden they code, it might be very hard for people to catch that was a tension pneumothorax without diagnostic imaging. Cardiac tamponade, another one that's high yield. Look for the jugular venous distension. Look for the hypotension, right? And then toxins, obviously toxins. We want to look for. UDS isn't going to be very fast. It might not be as fast as you'd like for it to be. Certainly, it could come back pretty quickly though. But if they're not peeing, then what can you do, right? You could probably get a urine sample from before. They probably have a Foley in. You could probably check for toxins. Maybe look at their medication history, see if they had taken any. If they had received any morphine recently, if they had overdosed on their opiates, then maybe that could be a reason why. And Narcan is a very, very quick and easy way to bring someone back to life. It really is. And then thrombosis, obviously coronary, PE, all those things are going to come into play. So what happens when you give CPR? The rhythm is and you check to see if the rhythm is shockable, and it's not shockable. And you do CPR again for 2 minutes. It's shockable. No. So if there's no signs of return of spontaneous circulation or ROSC, then you go to 10 or 11, which is you continue CPR for 2 minutes, epi every 3 to 5 minutes, treat reversible causes, do a pulse check. If you obtain ROSC, which means they came back to life, then you go to the post-cardiac arrest care pathway. And you also want to consider appropriateness of continued resuscitation. Now, this is where it gets tricky, folks, because this algorithm here is great, and I talked about it so beautifully, how there's, there hasn't been a point in humanity where we have a better way to save someone's life than now. We have all the optimized therapy for bringing someone back to life. But it's true that this algorithm only works for a certain amount of time, because theoretically, how often can you give compression to someone? Theoretically, you could give compressions forever, right? Forever and ever. Every 2 minutes, CPR, every 2 minutes, pulse check, epi. You could theoretically do this forever and ever. There's nothing in this algorithm that says stop. You could go on forever. But you have to ask yourself, is it worth it? Is it good to do that? You're keeping someone alive, that's great. No, you got to think about this for a second, folks, because you want to know if it's worth it to read. It's not about medical technology and you're wasting all these resources. Is it right from an ethical standpoint to keep doing this to someone, giving them so much pressure? They must have, you definitely cracked their ribs. Even if they come back to life, what is their life quality of life going to be like? What is their life expectancy after that, right? And I would talk to the family about this. I would have a shared decision making, have a discussion with the family, get them to understand the reality of the situation, get them to understand we can keep doing this, but it might be difficult to continue doing it for the patient and for the family. I would definitely have a discussion with them, and you should be calling family at some point during the code to get them to come to the hospital and see, give your last words and everything, because this is it can be a very stressful, high stress environment. A lot of things are going on, a lot of moving pieces, but it's okay to bring out your phone and get the cardiac arrest algorithm at hand. Okay, this is for adults. This is for age 18 and older. You want to do this. You want to pull up the information and follow the algorithm, because even the best of attendings do this. If you don't, then you're putting your patient at risk, right? And if you do you get out your code cards or your info sheets and everything, your cheat sheet, nobody should be faulting you for that. Nobody should be criticizing you or ridiculing you for, oh, you don't know the ACLS guidelines, you should know this by now. No. Folks, if anyone's doing that, they are malignant. You should not associate with those people. It is okay to bring out the information, bring out your references and look at them while you're running the code. Because this isn't about who cares if you know it or you don't. You want to have it on you so that you can look at it. So I hope this video finds you well. I hope that this helps you. Again, the best indicator of someone coming back to life through a code blue is good CPR. You want to push hard, at least 2 inches, and fast, 100 to 120 beats per minute, and allow the chest to recoil back. Okay, minimize interruptions and compressions. Avoid excessive ventilation. Good CPR is very, very important here. Okay, I really wanna send that message across the internet, because if the person giving compressions is not giving good compressions, then the chances of survival is going to go down drastically. I hope you find this information good. Leave a comment down below if you have any questions. I'd be more than happy to answer them. Please like, subscribe, share this video. I will see you all in the next video, and take care.